of Cardiology at the Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore, India. I have here with me Dr. Pamela who is the Director of Electrophysiology in the University of Virginia, United States of America. Welcome, Dr. Pamela.
Thank you.
So how has your time been in CSI today?
It's been wonderful. This has been my first time attending the conference, and it's been an incredibly rich experience. As someone coming from a foreign country, it's amazing to get to see the different ways people do things. And of course, there's a lot of similarities too.
Okay, how do you compare this with a large meeting like an ACC?
So I find it to be a little bit more of a personal experience. The American College of Cardiology meeting has 25 to 30,000 people every year and is a little bit overwhelming. This has been really nice because it's been a little bit more personal, and you feel like you get to meet more people and make more connections.
So has it been your first CSI, or have you been to the Cardiology Society conference before?
This is my first time at the meeting, but I'm hoping to be able to come again.
Oh, well, we'll invite you. Not a problem. So now I know that you are the Director of Electrophysiology and you deal with lead management issues. Am I right?
That is correct, yes.
Yes. Can you tell us something about lead management, please?
Yeah. Lead management is a very specialized field, and I think that this is something that you'll see worldwide, and certainly it's true in the United States. To do it safely requires a good bit of training and having the facilities to be able to support it safely. And if you look at the literature and the data, it's actually a fairly safe procedure as long as it is done by somebody who has the experience and the training.
So how many centers in the United States do you think do lead extractions?
I don't know exactly how many in the United States. I live in the state of Virginia, and in the state of Virginia, there's probably about 5 centers total for the state.
Okay, so that's not too many, is it?
No.
So it requires specialized training.
Yeah.
Now, can you tell me something about the indications for lead extractions?
Yeah. So the biggest indications we have for lead extraction are, of course, infection. And that includes both pocket infections and lead infections or device-related endocarditis. And I think there's oftentimes the fallacy of people thinking that pocket infections don't need to have a full system extraction, but really they do. The literature shows that if you have a generator that's infected, the leads are infected as well, and if you don't extract the whole system, the patient's very likely to have recurrent infection, which could be sepsis, so very dangerous infection.
So how quickly do you think you're going to consider extracting a lead in a patient who's got either an infective endocarditis or a pocket infection?
The most recent data shows that early extraction is always going to provide the patients with the best outcomes. It appears that earlier extraction, the patients are more likely to clear the infection quickly, they're less likely to have complications.
So would you adopt a transvenous extraction or a surgical extraction? Are there any differences in the outcomes, or which one is better, you think?
Yeah. I think we've reached a point where the vast majority of patients we recommend for a transvenous extraction as opposed to a surgical approach. The surgical approach is obviously much more invasive, and the data is really quite good for transvenous extraction, even in the setting of having vegetations which could embolize. The patients seem to do quite well.
So when would you suggest surgical extraction in a patient?
So surgical extraction we tend to reserve for patients who have endocarditis that has damaged a valve to the point that they need surgery anyway. So if a patient has developed severe aortic regurgitation, an abscess, or has a fungal infection, something that would indicate that they need surgery anyway, then we just let the surgeons take out the leads at the time of the surgery.
So what is your impression of doing an extraction in a small child? Do you have any experience?
So I personally don't do pediatric cases. I do a fair amount of patients with adult congenital heart disease who received leads as a child and then as an adult develop lead issues. But for children, I think the concern many people has is the size of the child versus the size of the sheaths. That you don't want to certainly cause them complications, vascular tears with the very large extraction sheaths.
So can you tell us something about the various tools that are available today for lead extraction?
Yeah, there's we call them powered sheaths. And Generally what we think is when leads have been in place for more than a year, you have to assume that there's fibrosis involved, that the leads have been scarred into position, and you're going to have to do something assistive to get it out rather than just retract the helix if it has one and pull it out. So the two forms of powered sheaths are either a laser sheath, which is manufactured by Spectranetics, or mechanical sheaths, which Spectranetics has its own set of those sheaths, and then Cook Medical, which I don't think is available currently in India, also has its own set of mechanical sheaths. Most of us originally trained on the laser sheaths because that was the initial way that we started extracting the leads. It has great data behind it. There was a large registry now more than 10 years ago called the Lexicon Registry that showed that high volume centers had very good outcomes with the laser sheath. But increasingly, we're getting really good data with the mechanical sheaths as well. There was actually the Cook mechanical sheaths actually just published a fairly large prospective study showing that those patients did very well with those sheaths as well. And we assume those to be analogous to the Spectranetics mechanical sheaths as well.
What are the lead locking stylets that you use in your practice? Because for all these extractions, you need to put something inside the lead to stabilize them, to pull it out, because otherwise I think the inner coil gets sort of distracted. So
the hallmark of using those powered sheaths is having created a rail such that you have something to safely advance the sheath over. And so you have to lock the inner lumen of those leads. Spectranetics makes a very nice system that actually expands and locks the entire length of the lead. Cook Medical makes one that locks just at the tip. So many people prefer the Spectranetics ones because it locks that entire length. But once you've locked the inside, then you can pull back on that lead and create a rail such that those powered sheaths can safely advance over them without pushing into the wall of a vessel.
So is there a difference between the Cook locking device versus the Spectranetics, or now I think it's called the Philips?
That is correct, yes. Yes, I'm calling it Spectranetics, but they were recently purchased by Philips. The Cook Medical one, I've used both of them, and I've had good outcomes with both of them. As I said, the Cook locks only at the very tip of the lead, but I haven't noticed any particular problem with that. Yeah.
Now, when do you use the telescoping sheaths? Do you use them at all nowadays?
So I do sometimes use the telescoping sheaths. I like to avoid it if I can. The things that make me more concerned that they're needed are advanced age of the lead, defibrillator coils, and of course if you know there's going to be a lot of calcium, it always makes it more difficult to get the leads out.
So is there a difference between extracting a passive fixation lead and an active fixation lead?
I feel like there is. If you look in the literature doesn't actually bear out that there's all that much of a difference between extracting passive fixation and active fixation. Anecdotally, I do feel like there's some benefit to the active fixation leads. The tips do come free more easily. The passive ones, of course, those tines are embedded in the trabeculae. And of course, that's one of the areas where we worry about complications is perforation of the right ventricular apex, trying to get the lead out.
Now, what about the defibrillator leads? What about single coil versus dual coil leads? Do you have any difference?
Personally, so being an extractor affects the choices of what you choose to implant because you know what's easier to get out and what's easier to deal with it from a lead management standpoint. Personally, I almost never use dual coil leads anymore unless there's a particular reason I'm worried about the patient's ability to defibrillate successfully.
Is it more difficult to extract the dual coil leads?
Yes, I believe it is.
So which leads do you think are more difficult to, defibrillator leads are more difficult to extract? Any particular company?
Yeah. Well, one thing we've been dealing with in the United States is the St. Jude Reata lead.
Yeah.
So the St. Jude Reata lead was a defibrillator lead that was recalled by St. Jude, which of course is now Abbott because they were purchased by Abbott. And it was recalled due to this problem where the interior cables would erode through the exterior wall. And the early experience with trying to extract those leads was very complicated because with the powered sheath sliding over the lead, they would essentially snowplow those cables forward. Now I think most of us are trying to pull those cables back into the lead and either marionette them or tie them with a little device we call a bulldog or something of that nature, and they come out fairly easily. In general, I think Medtronic leads are very straightforward to extract. They hold together very well. The inner lumen stays together. Boston Scientific tends to be they're much more friable leads. They tend to come apart. The inner coil lets loose. The St. Jude ones, if it's not one of those Riatas, tend to be fairly straightforward to get out.
So now when you're doing a transvenous lead extraction, you can go either from above or below, from the femoral. When would you sort of go from a femoral route to do a lead extraction? And what sort of equipment would you sort of use to sort of extract the lead from the femoral site?
We tend to use a gooseneck snare to try to get out these leads. Issues that would prompt us to take that as a primary approach. The biggest one is when you have a lead that's been cut. So once in a while we'll have a patient referred into us that somebody previously cut and abandoned the leads, but often the leads are infected and still need to come out. And so certainly there's nothing to grab from the pocket to be able to extract it that way. So that's probably the biggest case that in my practice we go straight to a femoral approach.
Now people have the habit of cutting the leads. What would be your advice if a person wants to abandon the lead? Should he cut it or just cap it and leave it in the pocket?
In general, it's probably going to be better to cap it and leave it in the pocket. Even if a patient doesn't have an infection, they could develop one in the future. And especially if someone pulls the lead taut, cuts it, and it retracts into the central vein where we can't get to it, you could be leaving your patient with a very bad problem, and then they could need open heart surgery, essentially, to get out an infected lead, as opposed to they potentially could have had a transvenous, very safe procedure had it been accessible.
Is there any difference between a lead explant versus a lead extraction?
We tend to use the terms interchangeably, but it is worth noting that leads, especially if it's younger than a year old, oftentimes pull free without an assist device, and it's very, very safe and a low risk.
Assist devices meaning one of those specialized devices other than the stylets.
Yes.
The regular stylets which we use for an implant, suppose we use something like a stylet, then we get the lead out very easily, then it's called an explant. And if you use some specialized equipment like a lead locking stylet or a lead locking device and the powered sheets, you would call it as an extraction.
Yeah.
So what are the complications that you would be worried about, and how would you explain it to the patient about complications of extraction?
So one of the challenges as somebody who does lead extraction is that how do you prepare for very rare but potentially catastrophic complications? If you look in the literature, it's overall a safe procedure provided that it's at a high volume center with very well trained extractionists. But the things that could go wrong that are really concerning are an SVC tear. Okay, so that's the first thing that we worry about, and that goes to your question about the dual coil leads, because of course having that superior vena cava coil probably increases that risk of the patient having an SVC tear. And then the other problem, of course, would be right ventricular perforation when we're trying to get the tip of the lead out. If you look in the lexicon data, the risk of dying from a lead extraction was well under 1%. In fact,
I think it was 0.28%, which is much. If you look at the major complications, it's about 0.28% in the lexicon registry, versus in a PCI, it's about 4 to 5%, which is probably. But one should realize that it should be done in a very specialized center. Now, how would you prepare your lab? You know, when you're doing an extraction, what sort of is it done under local anesthesia or?
No, we take a very multidisciplinary approach to doing this procedure. It involves cardiac anesthesia, cardiac surgery, our echocardiography colleagues, and the way we do the procedure is we do it in a fully OR-capable electrophysiology laboratory. So it has all of the OR equipment as well as fluoroscopy and all of those things. We use general anesthesia. There's a transesophageal echocardiography probe placed, and there's monitoring during the extraction procedure. And then our surgery colleagues actually have the perfusion equipment available, and they stand by should we have one of those very concerning complications. And hopefully they're bored and have nothing to do.
What about the bailout balloons? Do you keep them in a standby? Do you keep a wire in the SVC before you start the extraction from the femoral?
We keep a wire in the SVC before we start. We do keep the bailout balloon available. If we think it's a very high-risk situation, so maybe a defibrillator lead that's very old with the superior vena cava coil, sometimes we will prep the balloon and have it, more closely available should we need it.
So can you tell me how the bailout balloon works? Because obviously when you inflate the balloon, you're just going to obstruct all the venous flow from the head and neck. For how long do you think you could keep the balloon open?
Well, it's interesting because that was always everyone's concern.
Because you'd have cerebral edema if you had the balloon.
Yeah, so that was always the concern when that product was released, is what does this mean for the patient if we're obstructing the flow? So basically the idea is if you have a superior vena cava tear, you blow this balloon up and basically tamponade it. The data that's available actually shows that probably due to other venous collateral flow that the patients seem to do fine until they can get to the OR.
So how long does it give the surgeon to open the chest once you have the balloon up?
From our perspective is that those patients need to have surgery available so that they can get in several minutes, regardless of what kind of complication or regardless if the balloon is used. So we always have a full chest wall prep, all of the equipment available, the surgeons in the room. We've got transesophageal echocardiography and fluoroscopy, so if there is a complication, we know immediately, and the patient has what they need immediately for the surgeons to get into their chest in several minutes.
Is it much easier to extract a pacemaker lead or a defibrillator lead? And what about a coronary sinus lead? How easy or difficult is it to extract a LV lead?
So the easiest leads to extract are usually the coronary sinus leads.
But we are scared, right? We think that there is likely to be more complication because the lead is in the coronary veins, and if you tear that vein, you might have tamponade. But fortunately, it comes out much more easily. What is your experience with the new active fixation lead from Medtronic? Is it easy to remove?
Coronary sinus lead?
Yes.
I actually don't have any experience extracting that as of yet.
So we don't know how
know.
difficult or how easy it is to extract. So is it easier to extract temporary pacemaker lead or a defibrillator lead?
Pacemaker lead for sure.
For sure.
First, they're smaller.
Yeah.
And then those defibrillator coils, even with all the advancements that the companies have had as far as backfilling and coating them, they still provide a nidus for scar tissue growth.
So coming to the backfilling, does the backfilling make any difference to the way the leads get adhered to the venous system?
Yeah, I think it probably helps some, but again, those coils are just prone to ingrowth, and it's an issue.
So, what should be the training program for a lead extraction? A person who wants to do a lead extraction, can anybody sort of just go ahead and extract a lead, or do you think that you require some training to extract these leads?
Yeah. So the Heart Rhythm Society actually has a consensus statement about training for lead extraction, and actually has very specific guidelines, not just about training, but about maintenance of qualification to do it. We really want to avoid a situation where someone's doing 3 or 4 leads a year. This is an area where every case is different, every patient is different, every lead is different, and there's really no substitute for experience.
Yes.
And so, in general, I believe the Heart Rhythm Society guidelines recommend 70 leads to even say that you're competent to do it, with 20 per year to maintain competence. And when I actually do train fellows to do this, and I advise them when they go into practice to still have a mentor available, that you probably don't want to go into practice and be doing them completely by yourself to start.
So how many, to maintain the competence, how many extractions should you do per year?
How many did the guidelines say, or how many do I think?
Both. Let us have it both ways.
I believe 20 leads is what the guidelines say.
But for you, what do you think it is?
I think, first of all, there's the whole issue of leads versus patients, which is actually a different thing. I think 20 leads, that could be in 4 or 5 patients. So personally, I would think a minimum of 20 patients, and ideally more.
Yeah. there are various indications which include one of them is infection. Then what are the other indications you would suggest extraction?
Yeah. Other reasons we do is in the US, we will extract non-functional leads for several reasons. One, if they're causing the patient a problem. For example, superior vena cava syndrome, that we'll sometimes see if people have just dropped in more and more and more leads. And the guidelines actually do say that if you're going to have more than 5 leads total through the superior vena cava, or more than 4 leads from one side through the superior vena cava, you probably should start taking out leads.
What about the abandoned leads? And some of these leads, if they are cut, they can cause arrhythmias. So would you try to extract them also?
Yeah, it's certainly an indication to extract if you think that the lead is going to mechanically cause a problem for the patient, whether it's the risk of perforation because it's fractured and has externalized components, or as you said, if it's causing arrhythmia because of loose components.
Now, what is your thoughts about pulling out leads which have perforated? The perforated, acute or subacute perforations, and some of them are chronic perforations.
Right. For the acute and subacute perforations, we almost always get away with it, as far as just pulling it back. Of course.
So the right ventricle is very
muscular.
Muscular and
yeah. So we're cautious about it. We have echo available, and pericardiocentesis kits, but we generally just pull them back, and the patients seem to do just fine. As far as chronic perforations, we don't see so many of those, but there is concern that it's fibrosed and the hole is more likely to be durable once you pull the lead back. So then we're a little bit more cautious with having surgeons available.
So how many times do you think that you require the surgeons to be ready to open up? How frequently do you have a complication in your lab?
For lead extractions?
Lead extractions.
I've been doing lead extractions at the University of Virginia for 12 years. I had one other colleague who was doing it as well. And in 12 years, we've had to open 3 times.
So that's not too bad. So are you going to be here for some more time?
Yes.
Are there any interests other than electrophysiology that you have?
Yeah. I'm a comprehensive electrophysiologist.
So you don't have any other?
Well, my general area of interest is complex device management in general. Particularly, I enjoy dealing with biventricular devices, but I do ablations as well.
So do you do complex ablations or just?
Yes.
So I think we will end the talk here.
All right, very good.